pediatrics, and she's the teaching faculty too. Congratulations, that's nice. So Dr. Sally will talk about cystic fibrosis complications and comorbidities.
Hello everyone, my name is Sally. I am a pediatric pulmonology fellow at E.U.P. I'm very excited and happy to be here with all of you. And today I'm just going to talk about cystic fibrosis complications and comorbidities. Feel free to chime in at any moment if you have any questions or need any clarification. So the outline of the talk today is going to be about challenges in CF, pulmonary complications including pneumothorax, hemoptysis, hypercapnic hypoxic respiratory failure, pulmonary hypertension, liver complications, GI complication, and CFRD, which was sort of covered in the previous talks. So some of the challenges in CF is that it's a multi-system disease. It impacts a lot of your organ systems, and so it impacts your respiratory system, your GI tract, your pancreas, your sweat glands, vas deferens in males, and obviously your immune system, and then the very thick mucus, which is the reason for a lot of the issues that patients with CF suffer from. So I'll begin by talking about pneumothorax, which can happen spontaneously with an average annual incidence of 0.64%, or about 1 in 167 patients per year. The 2-year mortality is about 48%. Usually a lung transplant evaluation is recommended with the first occurrence because it's associated with sort of poor prognosis. And the risk factor includes severe lung disease with an FEV1 of less than 40%, any cysts or blebs or bullae present within the lung parenchyma. So this is what it looks like on X-ray and chest CT. You will see on the left side, this is your chest X-ray. The patient would typically present with shortness of breath. You can't really appreciate it all that well, but then when you get a chest CT, then you could see the large pneumothorax right here. And so usually it presents with acute chest pain, dyspnea, and tachypnea and hypoxemia. And you should suspect it in any patient who's presenting with a pulmonary exacerbation, because the symptoms can largely overlap between pneumothorax and a pulmonary exacerbation or a CF exacerbation. And you could see free air within the thorax on a chest X-ray, but oftentimes if it's a small pneumothorax, it could be missed, and you might need a chest CT to detect those. And so how do we manage pneumothorax? Typically, if it's small pneumothorax, like less than 3 centimeters, and the patient is clinically stable, then we can just observe them outpatient. We continue their airway clearance regimen and their medications. But if it's a larger pneumothorax, larger than 3 centimeters, we should observe them in the hospital, and we should hold their airway clearance and hypertonic saline and pulmozyme, because those can make things worse. And then if it's large enough that it's causing tension pneumothorax, then we should do tube thoracostomy or needle decompression if it's a tension pneumothorax and the patient is unstable. And then we treat it as a CF exacerbation with antibiotics. And so if you have a complication of persistent air leak, you might need pleurodesis. And in CF, the recurrence rate is high, with an estimate of about 15 to 90% recurrence rate. Moving on to hemoptysis, it is typically classified based on severity. So it can be scant, where you can have blood-streaked sputum, you can have mild hemoptysis if it is more than 5 cc's. It can also be massive if you have more than 240 cc's in one day, or 2 days of greater than 100 cc's. And it's usually the result of chronic inflammation leading to localized destruction of your airway epithelium, and then bronchiectasis, and then more growth factor production and bronchial artery wall hypertrophy. And so the bronchial arteries become enlarged, tortuous, dilated, and then they can rupture into the airway. And the incidence can be as high as 21 to 31%. And obviously, massive hemoptysis is a life-threatening emergency. You can have, the median age of hemoptysis is about 23 years of age. And so how do you manage hemoptysis? Usually, if it's a small or scant hemoptysis, you manage as a pulmonary, like you would for a pulmonary exacerbation. And then if it is mild or scant, you could continue your airway clearance regimen, but obviously in massive hemoptysis, you do not want to do your airway clearance therapies because that could also worsen and be more irritating to the airways and worsen your hemoptysis. In certain situations, you might actually need to do bronchial artery embolization if it is massive hemoptysis or the patient is clinically unstable. It is also associated with poor prognosis, and the attributable risk for mortality can range between 5 to 16%, and you have to think about a transplant evaluation at that point. Again, moving on to hypercapnic and hypoxic respiratory failure. With CF, if you have a lot of mucostasis, chronic airway infections, inflammation, you can have airway remodeling with progressive bronchiectasis and the development of obstructive lung disease. And so your ventilation perfusion mismatch becomes worse, and you develop chronic respiratory failure. You can have hypercapnia, hypoxemia, or you can have both. And typically the patients would present with morning headaches, fatigue, poor sleep quality if they're hypercarbic or hypercapnic, and hypoxemia or cyanosis if they're hypoxic. And then the way you diagnose that is through a blood gas and pulse oximetry. You can also do transcutaneous CO2 monitoring. And the way you treat those is with non-invasive positive pressure ventilation or just supplemental oxygen to improve their quality of life. And moving on to pulmonary hypertension, obviously chronic hypoxemia can lead to the development of pulmonary hypertension. It is characterized by pulmonary vascular remodeling, subintimal fibrosis, and muscularization of the pulmonary arterioles. And the incidence is unclear, but the rates can be as high as 57% in advanced cases of cystic fibrosis, typically diagnosed with thoracic echo. The gold standard is obviously the right heart catheterization, and the treatment is supplemental oxygen in chronic hypoxemia. There is actually no evidence that your typical pulmonary hypertension medications work in CF or are effective. And in case of acute respiratory failure, some patients might come in pulmonary hypertensive crisis and could need mechanical ventilation and be cannulated on ECMO. Moving on to a different topic of CF complications, which is CF liver disease. It is a non-pulmonary cause of mortality of about 2.5 to 5% of overall CF mortality. It's typically attributed to channelopathy, and because the CFTR gene is expressed in the CFTR receptor is expressed in the apical membrane of cholangiocytes, which is a major determinant for biosecretions. And so liver disease secondary to cystic fibrosis is a severe complication in the management of CF patients. And if it is severe, it can be life-threatening and can require a liver transplant. And so this is sort of the proposed mechanism of CF liver disease, and some potential treatment approaches. So we don't really have to go through the whole thing, but essentially, like I said before, in a normal cholangiocyte, the CFTR is expressed on the apical membrane. It regulates the alkalinity and fluidity of the bile, and it is associated with a multi-protein complex, SRC, tyrosine kinase, which controls toll-like receptor 4 signaling, regulating the innate immune responses in the epithelium. Any mutations in CFTR can lead to cystic fibrosis, liver disease. And so the bile secretions become very thick. There is reduced alkalinity, and it becomes thick and viscous, and it accumulates toxic bile acids and disrupt this protein complex, which results in increased toll-like receptor 4 signaling in response to gut-derived endotoxins, and that resulting in impacting F-actin and the tight junction integrity. So it really disrupts the barrier of the epithelial, it disrupts the epithelial barrier function. And so to the lack of CFTR in the gut alters the normal composition of your microflora or gut flora, which can lead to dysbiosis, inflammation of the mucosa, and then leakage of the bacteria through the portal circulation into the liver and leading to more damage. And so obviously CFTR modulators like Trikafta has a lot of potential in improving CF-related liver disease. And so how does it present? Usually it can be asymptomatic, and you can have just abnormal liver enzyme values like elevated AST, ALT, ALK-Phos, GGT, and a bilirubin. You can have cirrhosis with or without portal hypertension, and sometimes you can have portal hypertension without cirrhosis, and that's called nodular regenerative hyperplasia. You can also have microgallbladder and steatosis. And typically, CF liver disease is related to the more severe mutations, class 1 to 3, pancreatic insufficiency, male sex, and meconium ileus at birth. And so how do we treat CF liver disease? Usually we use ursodeoxylic acid, and for liver cirrhosis we can use supportive treatment, especially if you have portal hypertension. You can use beta blockers, or you can do the TIPS procedure. You can also do liver transplants for severe liver dysfunction, or if the liver failure is impacting the function of other organs like the lungs. This is just, again, what I had talked about before. This is like an image to demonstrate what I had talked about before. And so again, this is another graph that shows that with increased CFTR expression, then this controls your pH, and as a result, if you have a balanced acid-base balance, then the function and the fluidity of your secretions are appropriate. And so with reduced CFTR expression, then you're risking all of the complications that we had talked about before. So in conclusion, usually CFTR is critical for the digestive system. I always like to think about CFTR present in any like the hollow organs that need ducts and conduction, and so any patients with CFTR dysfunction can have obstructive like meconium ileus, they can have pancreatitis, and then subsequently develop exocrine pancreatic insufficiency, increased acidity, microbial dysbiosis. This is more of the same stuff. I'm just going to skip over these. I wanted to talk about microbial dysbiosis, And so when your gut microbiota is altered or less diverse in the setting of CFTR dysfunction, you can have unfolded mucin, which fails to trap the microorganisms and then transport them away from the epithelial surface. And so your pH is suboptimal to be appropriate for defense against microorganisms. And so you can have subsequently develop spontaneous intestinal bacterial overgrowth. It's typically present in about 50% of patients, and they present with diarrhea, abdominal distension, flatulence, more steatorrhea, and they can have macrocytic anemia and weight loss. And then the bacteria can also metabolize, which can consume more nutrients, which then the bacteria is consuming the nutrients that the patient is trying to make use of, and so that can lead to their malnutrition and fat malabsorption. And so usually it's, again, more of the same thing, altered diversity and cell density of your colonic microbiota, and then increased degradation of your short-chain fatty acids, and that limits the fat absorption and leading to more pro-inflammatory results. And so the good bacteria can reduce your inflammation, and so if you have less of those and more of the pro-inflammatory bacteria, then this is what dysbiosis is about. And so they mainly can reduce your fat absorption. You can have high proteobacteria present, which is basically E. coli. And then if you have less of the anti-inflammatory good bacteria, like lactobacilli, then that is just poor biosis, and so more complications. And so what are some of the causes of dysbiosis? Usually chronic exposure to antibiotics. We all know that the antibiotics can kill the good gut bacteria and lead to overgrowth of the bad pro-inflammatory bacteria. Delayed small bowel transient time, abnormal pH because of the dysfunction of the CFTR receptor, and then pancreatic insufficiency. Prolonged use of acid suppression medications can lead to dysbiosis. A lot of RCF patients can have associated GERD and acid reflux, and so a lot of the patients are on acid suppression. And to having a high-fat diet, which all CF patients need, can also lead to microbial dysbiosis. And so, again, symptoms are basically diarrhea, abdominal pain, a lot of bloating, and then usually the way you diagnose dysbiosis is with stool analysis. You can do a PCR culture, and you can do ELISA to detect C. diff toxins. And so what is small intestinal bacterial overgrowth, or SIBO? Usually the definition is if you have more than 10 to the power of 5 colony-forming units per milliliters in small intestine with colonic and anaerobic predominance. And it contributes to the synthesis of enterotoxins and unabsorbable metabolites, which causes further mucosal damage, poor digestion, and nutrient absorption. It's present in about 30 to 55% of patients with CF. And typically, it's a similar cause like dysbiosis. So you can have, or the causes can be delayed small bowel transient time, abnormal pH, pancreatic insufficiency, and prolonged use of acid suppression medication. The symptoms are very similar to bacterial dysbiosis, and the diagnostic testing is usually with direct aspiration of small bowel fluid with cultures and then determination of the bacterial count. And the limitation to that is that you could miss some of the bacteria that's present in mid or distal small bowel, and then You could have contamination from oral or esophageal flora. You could also do the hydrogen or methane breath test, which is an indirect assessment of spontaneous intestinal bacterial overgrowth or small intestinal bacterial overgrowth, which measures a byproduct of bacterial fermentation. But then the cutoff values are usually lacking, so we don't really know. And so moving on to the pancreas and the pancreatic anatomy, you have two parts or two functions to your pancreas. You have the endocrine and the exocrine function. The endocrine pancreas is structured as the islets of Langerhans, and while the exocrine pancreas is comprised of ductal and acinar cells. So there are two types of exocrine cells, and there are 4 cell types of the endocrine function. And so the pancreatic enzymes, the amylase and lipase. Amylase is important for digestion of carbohydrates. Proteases help with the digestion and absorption of proteins, and then lipase breaks down lipids and is essential for lipid absorption. And so if there is damage to the pancreas, then you can't digest or absorb your nutrition or fat or proteins. And so the definition of exocrine pancreatic insufficiency is the reduction of pancreatic enzyme quantity and or activity to a level below the threshold that's required to maintain normal digestion. And so with reduced production from the loss of pancreatic parenchyma, reduced endogenous stimulation so you lose pancreatic parenchyma from CF, and that typically happens before the kid is even born. And then you can also, so like some of the mechanism of reduced production is the lack of endogenous stimulation, usually secondary to celiac or Crohn's disease. You can have reduced delivery of those exocrine pancreatic enzymes if there's an obstruction in the pancreatic duct, so like for example, pancreatic tumors, or there's reduced activity, and that's typically secondary to like gastric pancreatic resection. But in CF, it's mostly about the damage to the pancreatic parenchyma and decreased production of those enzymes. And so there are also obviously other conditions that can interfere with your exocrine pancreatic function that are like, it could potentially be in the differential diagnosis. So acute pancreatitis, Crohn's disease, gastric surgery, or celiac disease can interfere with the function of the pancreatic enzymes. And so what is the clinical presentation and what are the symptoms of exocrine pancreatic insufficiency? You can have lots of bloating, lots of flatulence, abdominal pain, diarrhea, and steatorrhea. And it typically presents with weight loss. They can have skeletal muscle loss, failure to thrive, malnutrition. They can have low fat soluble vitamin levels, and they can have a bleeding tendency, easy bruising because of vitamin K deficiency, and they can have impaired quality of life. And so this sort of just demonstrates what steatorrhea looks like. It's just lots of oil bubbles floating on the top of the water surface in the tub. And so typically we treat with replacement enzymes, and it's the cornerstone of management of exocrine pancreatic insufficiency. And it's basically a combination of porcine-derived lipase, protease, and amylase. And it's very, very important for patients with CF. And the way you tailor your dose is based on what is the patient weight, what is the fat content of their diet, and some of other underlying conditions. And obviously the dose can be different based on their clinical symptoms, how much fat is in their diet, whether they're taking a meal or a snack, and how much fat content is in the diet, and their symptoms of diarrhea, so how much of that they're having, and that will kind of guide the management and the dosing of the pancreatic enzymes. And so what are some precautions that the patients who are taking replacement enzymes have to think of? Obviously, it can be irritating to the oral mucosa, and so they should not chew on their enzyme particles or retain it in their mouth. They should be very careful, or we should be very careful when prescribing them to patients with gout, renal impairment, or hyperuricemia. We should also worry about any sort of allergic reactions or any known allergy to porcine proteins. You can also develop fibrosing colonopathy. It's been reported very rarely in patients with cystic fibrosis taking very high doses of replacement enzymes. And so in summary, exocrine pancreatic insufficiency occurs when there's a reduction in pancreatic enzyme quantity or the activity to a level below the threshold that's actually required to maintain normal digestion. It's associated with pancreatic and non-pancreatic conditions, including CF, chronic pancreatitis, pancreatic surgery, pancreatic cancer, and among others. And we should evaluate them. We should have high suspicion for CF in a patient with exocrine pancreatic insufficiency. And nowadays, because of the replacement enzymes, their care is much improved. And so moving on to the last topic, which is CF-related diabetes. It's very different from your typical type 1 and type 2 diabetes. And I'm just going to talk about CFRD. So the most common age of onset is between 18 to 21. Usually they're thin, but nowadays we are seeing some overweight patients with CF. They have low insulin secretion, low insulin sensitivity. It's not an autoimmune etiology in contrast to type 1. They can have amyloidosis of their islet cells. It's rare that they get into ketoacidosis, but it has happened. They are at risk for having microvascular complications, but not much macrovascular complications. And so what is unique to CF, or CFRD is unique to CF, and why is that? They are typically malnourished. They have chronic inflammation with intermittent acute exacerbations. They have glucagon deficiency, and they have altered intestinal nutrient absorption and transient time. In addition to hepatic dysfunction and increased energy expenditure. And they're typically thin, they have low lipid level and normal blood pressures compared to the other types of diabetes. So how does it typically present? They can have your classic polyuria and polydipsia. They have failure to gain or maintain weight despite nutritional interventions, optimization of their enzymes, more failure to grow, delayed progression of puberty, and chronic decline in pulmonary function. So how do we screen? Usually, and this is a topic that was covered in earlier talks, so I'm not going to spend too much time on it. So you measure preprandial and 2-hour postprandial glucose monitoring for high-risk patients that are typically over the age of 10. If they're taking high-dose oral corticosteroids, if they're having frequent CF exacerbations, and obviously excitement. We typically check, we screen every year for all patients over the age of 10. including those that are pancreatic insufficient. So you don't have to have pancreatic insufficiency to be at risk for CFRD. And if your if your glucose is over 126 or your fasting is over 100, then you move on to doing your 2-hour oral glucose tolerance test. We use hemoglobin A1C every year as a screening measure, but it's so it's not sensitive to establish the diagnosis, but it's a good tool for follow-up and trend. And so oral glucose tolerance test is the most sensitive way to detect CFRD without family history. And it should, again, be considered for all patients over the age of 10 with symptoms of diabetes and a random glucose of 126 or a fasting glucose test of over 100 milligram per deciliter. It's very important to identify those patients because they have a high risk to progress into fasting hyperglycemia and more decline in pulmonary function. And so the criteria to diagnose CFRD is fasting plasma glucose of over 126 on more than 2 occasions, and they can have a random glucose of over 200 on 2 separate occasions with symptoms. They should also have fasting plasma glucose and like a random glucose of over 126 for fasting and over 200 for random glucose. And then for oral glucose tolerance, their 2-hour plasma glucose level is typically over 200. And so in summary, diabetes is common in CF. It is important to routinely screen patients with CF for CFRD, and it is a distinct form of diabetes that it requires its own management approach. It should be flexible. We should be very mindful of their nutritional issues and adjust when they're acutely ill because their blood glucoses are going to be higher in the context of an illness. This is all I have. Thank you very much. I'm happy to take any questions.
Thank you, Sally. Perfect. We have a lot of questions.
Yeah.
First, I asked about hemoptysis and C.
Yeah.
Do you see it common? Complication?
Not as much. It's mainly, we see it more in the teenagers that are not very compliant with their airway clearance. Typically, they're older and they're usually not on modulators, and they're usually like delayed in like the introduction of Trikafta, so it's typically in the older kids.
We haven't seen it recently because they are too much blood.
Yeah.
So usually you see it in more moderate severe disease, anything. And a lot of the time I tell the patients when you have hemoptysis, you have to be admitted because that's an indication that you have infection. So the infection eats up on your bronchial circulation, and then you end up with it. So I have patients that have hemoptysis and don't want to be admitted. And I tell them, even like if it's a small amount, I need to observe you. Mm-hmm. So if it's a small amount, if it's blood tinged sputum, I can treat them at home. But in general, if there's any blood coming out of their mouth, we admit them unless we think it's from the nose. So yeah, it's mainly indication of moderate to severe lung disease. Yeah, you can lose them from hemoptysis. It's a bad prognosis, and you really have to be very careful. And if they have it, like Sally said, if they have an incidence of it, the 50% chance of coming back. So we usually watch them very carefully. Okay, that's a very good question. Do we bronch them? We try not to because, so bronchs, we love to do bronchs, and we rush to do bronchs if we, there is an indication. For hemoptysis patients, we walk very slowly to go to the bronchs because we don't want to do it because you never know what you would see when you go in. So we usually, our team, God bless them, they usually have the normal setting on ice. And we usually do it very carefully. I mean, if you have it at the beginning, I do only bronchs if you're gonna do an intervention and we're gonna do give the thoracic surgeon to do the coiling. But if you have a prognosis and if they're improving with your antibiotics, we don't necessarily do it. We hate doing it. Because you never know. I mean, you go in and bloody,
Bloody mess.
yeah. But it's maybe indication of water is
I have a question from the pharmacist Corey. And you mentioned the dysbiosis, and there's a lot of buzz now on probiotics. We have a lot of probiotics in the market. I understand that these patients will continue to take antibiotics and protein pump inhibitors and so forth. Is there a role for probiotics?
There's not been many studies on the role of probiotics in patients with CF. It wouldn't necessarily hurt, but there's very limited studies on the benefit of probiotics.
So there are some parents that believe strongly in probiotics. We do not stop them if they want to do it.
Yeah.
Some of them do it automatically if you give them antibiotics, but a lot of them don't. So it depends on who you're working with. I haven't seen it making a huge difference if the patient's on it. So it's really if the parents really want it, I usually tell them, okay, fine, you can do it.
Would there be a concern of interaction with antibiotics and selection of potentially resistant and harmful organisms?
Can you repeat the question, please? Is it about
So there is a concern when using probiotics, especially with antibiotics, that this will end up in some form of selection of resistant bacteria. And then you're gonna end up with like a super bad buzz. Okay. So I'm concerned with patients who have been taking so much antibiotics that if you give them the probiotics, then that's gonna end up in a scenario of resistant organisms being, difficult to treat.
To be honest, we haven't had much trouble with a lot of that. I mean, and typically the approach is from what I learned from our pharmacists is that they would typically try to cycle the antibiotics just to minimize the risk of resistance. And so even though they're when we do their cultures and they're sensitive to multiple antibiotics, we tend to, or the approach that the pharmacist would have is to cycle those antibiotics. So for example, if they get admitted and they've gotten, I'm just throwing out there, Cipro this time, and then the next time they're admitted, they would choose a different antibiotic to minimize the risk of resistance. Obviously, the biggest issues that we run into is some patients have multiple allergies, and so your selection is limited for antibiotics. And so sometimes you are stuck using the same antibiotic over and over. But for the most part, we had, with the support of our pharmacists, we've had good success and good results with minimizing complications of toxicity from the antibiotics and minimizing resistance. And there are more recent studies that have shown that even if you have a resistance, the resistance profile to antibiotics, that it's different in vivo versus in vitro. And if the patient is improving, even if their culture sensitivity analysis is showing that they are resistant to this antibiotic, if they are improving on that antibiotic, then we just keep using it even if they are resistant.
So a couple of things. We don't use enough probiotics to answer your question. So we don't know if it really add to resistant bugs or not. So we don't use it. It's mainly patient preference, and a lot of the time it's mild patients that they don't want that. The second question, you really answered it very nicely, is that if you have a resistance, which in Egypt, most of the patients are resistant to every antibiotics because of the multitude use of antibiotics. We still use resistant antibiotics that the organism is resistant to, because like Sally mentioned, in vitro studies is different than in patient. The sensitivity is done on mainly blood samples rather than sputum, so they still can work on the lungs. So we do a lot of that. I mean, for stock we use resistant because also we use two of them, then one is resistant and one is sensitive. The synergy is actually even.
Question?
No question?
Okay, this is the end of today. We take a photo before we leave. Thank you, Sam.
Thank you guys so much for listening.
Everyone.
Really? Okay. Happy to.
Amount of time, except they pick all that stuff.